Hello class, today we'll be presenting a patient on a cardiovascular event in clinic. My patient's initials are MR. Her date of birth is 10/17/1957. She is a 68-year-old female Caucasian presenting to evaluate for new onset palpitations and fatigue. She is a reliable historian. As stated by my patient, my heart feels like it's racing and fluttering, and I have been so tired lately. She does have a 1 month history of non-intense palpitations, which she feels as a fluttering and at times a forceful racing of the chest. They are irregular, ranging from 10 minutes to an hour, and they do occur about 2 to 3 times a week for no particular reason. They are not related to any sort of physical activity, nor does she have any pain in the chest when these occur. She does complain of severe diffuse fatigue and periodic lightheadedness during these episodes and has therefore restricted some of her activities of daily living. She does not complain of any syncope, no chest tightness, no shortness of breath. She has not had any recent illnesses, no fevers. Her biggest concern during the visit was the disturbing feeling of the palpitations and the heavy fatigue. She does have a history of hypertension, osteoarthritis, and she has a surgical history of a total hysterectomy in 2008 and a cholecystectomy in 2015. In regards to medications, she is on lisinopril 10 milligrams PO daily and hydrochlorothiazide 12.5 milligrams PO daily. She does take acetaminophen as needed, and she does have an allergy to penicillin. All of her vaccinations are up to date. In regards to family history, mother was deceased at 78 from a stroke, also had history of hypertension and atrial fibrillation, and her dad was deceased at 82 from colon cancer. Her brother is alive, 70 years old, and has history of hypertension. She is widowed, lives alone, and is now a retired teacher. She denies any tobacco use, no illicit drug use, does drink 2 to 3 glasses of wine per week, and does have activity limited to light walking because of her fatigue. Review of system, generalized. So if she is fatigued, she denies fevers, chills, or weight changes. Cardiovascular, she does have intermittent palpitations, and then she has occasional lightheadedness, no chest pain. Respiratory, she denies dyspnea, cough, or wheezing. And endocrine, she denies any heat or cold intolerances. Neurological, she denies syncope, headaches, and vocal weaknesses. And in regards to psychiatric, she does deny anxiety, but does get on edge because of her symptoms. Her vital signs were 138 over 84. Her heart rate was 112 beats per minute, irregular. Respiration was 16 beats per minute, and temperature was 98.4. Her O2 saturation was 98% on room air. Generalized appearance, she's alert, oriented, she's cooperative, she's in no acute distress. Cardiovascular, we do have an irregular rhythm with a tachycardic rate. S1 and S2 were audible. No murmurs, no rubs or gallops. Carotid pulses were +2 bilaterally. No jugular venous distension was noted. And then she does have pitting edema on bilateral ankles, and it's like +1. Respiratory, her lungs were clear to all auscultation. Bilaterally, no labored efforts for breathing. Again, she's alert and oriented ×4. There was a 12-lead EKG that was done in office. Atrial Fibrillation with the rapid ventricular response was noted with an average rate of 115 beats per minute. No acute ischemic changes. So for the primary diagnosis, we're going to go with atrial fibrillation with RVR. During examination, the patient did demonstrate symptoms of palpitations and irregular tachycardia with a confirmation on the EKG results. So strong predisposing factors of this patient would be her age and then her history of hypertension. For differential diagnosis, we have hyperthyroidism. It could be a possible cause of the atrial fibrillation. Bimetabolism, which is probably unlikely though, without any other typical signs, but should be ruled out either way with the blood work. And then second differential diagnosis would be anxiety or panic disorder. Palpitations are a big characteristic of the anxiety. And the EKG shows an organic arrhythmia as the leading cause. The other thing we would know would be another differential diagnosis would be PCs or PVCs. These do give the feeling of like fluttering in the chest, although the protracted irregular rhythm is typical of atrial fibrillation. So for the plan, we do have the diagnostic labs, which should be ordered stat. We do a CMP, a CBC, thyroid stimulating hormone, and then we also ordered the TTE, transthoracic echocardiogram. This is to assess the cardiac structure, the left ventricular function, and the left atrial size. In regards to medication, we started her on metoprolol 25 milligrams PO daily. The goal is to have a resting rate of less than 100 in order for her symptoms to improve. And then we do want to put her on a blood thinner, so we started her on Eliquis 5 milligrams PO BID. In regards to lifestyle and education, we educated the patient on atrial fibrillation, what exactly it is and what's happening to the heart during this time. We also talked about the reason for adding the new medications. This was in hopes of ensuring that the patient adheres to the medication regimen. And then we also included things to be aware of, such as like bleeding precautions. So look out for abnormal bleeding, nosebleeds, hematuria, and melena. And then we did educate on diet and lifestyle. So we emphasize the importance of blood pressure management through her antihypertensives, and then adhering to like a low sodium diet. And then we encourage the patient to light moderate exercises tolerate once the heart rate becomes controlled. We also advise to avoid alcohol consumption, which could precipitate the occurrence of atrial fibrillation. And we did refer her to cardiology just for continued management. We did have her follow up with the clinic in 1 week, so we can talk about the lab results and how the medication tolerability is going, talk about heart rate and blood pressure as well. We did ask her to return for any new signs or symptoms, and we did educate her on the importance of watching out for chest pain, severe shortness of breath, fainting, stroke symptoms, or severe bleeding. She was advised to go to the ER. Thank you for listening to my patient today.